So part two, what we're going to do, we're going to jump into some of the fun technology that we have. So the lenses that are now available, and then kind of how we talk to patients about it. So honestly, this is the part I think, Keith, you are our senior wisest person, but I think about your career arc and the improvement that you've seen in IOL technology. It's pretty remarkable. Maybe I'll let you jump in this first in terms of just, talking through, hey, what implants did we used to have? Not to say that you're ancient, Keith, you're young at heart, but what lenses now do we have that really have increased the opportunities that we have for patients?
Yeah, well, I think all implants, ranging from standard monofocal implants, toric implants, to even multifocals, have improved. I remember I was doing a fourth year rotation at the Moran Eye Center in Salt Lake, Utah, where you did, Russell. And there was a grand rounds on light adjustable lens back then. And I thought, oh my goodness, this is the future. Well, a year later, I joined Vance Thompson Vision and he's doing light adjustable lenses. So it's kind of fun to see, now it's 20 years later, we're still doing those. I think one of the main things that we're seeing in, monofocal is just being able to adjust for spherical aberration has been huge in helping out with nighttime issues. And then the same thing with any multifocal or diffractive or EDOF lenses, just improving image quality. It used to be back in the day, it was, we can do a multifocal for you, but your image quality and contrast sensitivity are going to be reduced. Nighttime glare is going to be kind of off the charts. And that was tough to deal with patients, and whether it was worth the investment and extra surgery. And nowadays with modern multifocals, and I know they're going to continue to improve and they're not perfect. We'll probably talk about that in a little bit, but I feel like we're almost in the golden age of multifocals, just how far we've come. And it's just so impressed, or I'm so impressed seeing patients not only being able to see distance near, but good nighttime image quality and just quality of life.
Awesome. Tanner, I'm going to let you jump in on this because, there's kind of two ways I think to think about the lenses. There's, we can jump into all the specifics of the lenses. The other view is kind of talking about, hey, what are the visual outcomes that maybe our patients are interested in? And then kind of what categories of lenses maybe fall into that. So maybe do you mind, and I generally think the, visual outcomes perspective is how our patients think and is maybe most helpful for us to think as doctors. So do you mind kind of walking through, what are the different visual outcomes that we could be thinking about for our patients with cataract surgery? And then what kind of classes of lenses fall into those sort of visual outcomes?
Sure. Are you trying to get at like how do they want to use their eyes with or without glasses?
Oh, this is a big test. It's kind of like trefoil and trefoil. I'm just seeing if you'll mess it up so we can harass you a little bit.
Take whatever you want him to have said and just run with it. Talk about whatever you want.
You can talk whatever you want about. That's a great part.
Ask more ambiguous questions, okay?
Yeah.
I think when I had the lens discussion with patients, I kind of frame it like, how do you want to use your eyes after surgery? And do you want to have some freedom from glasses? If your main goal is to have maximal image quality at distance and some freedom from glasses at intermediate, then I'm more thinking about light adjustable lens or an extended depth of focus lens. If their goal is to maximize their freedom from glasses as much as possible and not have to wear glasses for 99% of the things they do, then I think more about a trifocal option. And then there's a lot of nuance within that, or for other choices for why LAL versus PanOptix versus extended depth of focus. But I really start the conversation with, how do you want to use your eyes? And then in some cases, if the patient doesn't mind wearing readers and is most focused on having maximal image quality at distance and they have some astigmatism, I still think there's a good role for a monofocal toric. I'm still amazed that I do more monofocal torics now than I did during fellowship. And those patients are always so happy with their vision.
Yeah.
I'll add to what Tanner said too, and this is just kind of an overarching high level point. What we're seeing now that we have, for a long time we had those categories, the multifocals, and then and monofocal and toric, and then came extended depth of focus, and what we're seeing is further iterations on each of those things, and they're starting to blend between, right? We've seen a dramatic advancements even in monofocal technology that edge towards more of an extended depth technology. And so then now there's a new category called monofocal plus, right? So it's an incredible time to practice cataract surgery, which is, like Keith said, refractive surgery, right? And if it wasn't refractive surgery, this iteration of technology wouldn't continue, right? Because it wouldn't matter. So that's a great point, Keith. That is refractive surgery. The other thing I'll say that I'm going to contrast with Tanner just a little bit, and I think we're getting to the point, to the same point, but I do it a little differently. And this was a recent change for me. But instead of asking patients how they want to use their eyes after surgery, what I ask them is, how well do you want to be able to see without glasses? That's it. And I let them run with it. Totally open-ended. They can decide, whether they think I'm talking about distance or up close. They can clarify for me. And it's all about trying to get them to answer the question, how well do you want to see without glasses? They say, I want to see well without glasses, because who doesn't, right? It puts them squarely in the mindset that, okay, I'm going to have surgery. This is going to change my prescription. How well do I want to see without glasses? And what technology, and then they tell me, and I tell them which technology will help achieve that goal, right? And so I feel like it's simplified the process for me a little bit. So I hate to disagree with Tanner, because he is my junior, but I just take a slightly different approach.
Yep.
Yeah.
And mind if I add a couple of things? There's a couple other questions that I like to ask patients, especially myopic patients when they come in, especially females. Is, do you take your glasses off when you look in the mirror to do makeup? Or guys, do you, shave without glasses? Because that's an important question to ask the patients too, because if they're myopic and they read without glasses, or again, simple things like shaving or putting makeup on, it sounds kind of small, but when they do it every day, if they were myopic pre-op and we don't ask them that question, we put a monofocal and make them distance, they're not going to be happy when they're having to use a magnifying mirror to put their makeup on. And so that's something that I like to ask too, is if you're okay with glasses, and you'll wear them most of the time, but the small percentage of the time you don't have glasses on, would you rather see a little more at a distance or up close? And on top of that, I like to ask patients with progressive addition trifocal glasses, do you do okay with that? Some patients, it's not a lot, but there are some patients that are okay with glasses. They just don't want to wear trifocal glasses because they have a tough time stepping down a curb or off steps. And that's where I've even had a couple of patients recently that want to do a multifocal implant, but still want to wear glasses because they're just single vision glasses. Their grandkids won't know them without glasses. So they kind of like the fashion style of glasses, but they just don't like the maybe depth perception, issues that they're dealing with multifocal glasses.
Nice. That's a great point, Keith. And I'd be curious, anyone can take a stab at this, but I'm curious, sometimes I get asked from some of the primary eye care doctors here in Montana, how much of that conversation should I be having on the front end? And I guess I'd be curious kind of your guys' thoughts on, where does that conversation belong, whether it be in the primary eye care office or with us? And if you think it's helpful to be in the primary eye care office, what maybe tips you have for starting that conversation if it's somebody new?
Go ahead, Brandon.
No, this is a Midwest standoff.
No, Tanner. No, Brandon. No, Tanner.
I think it's really helpful when
Brandon won.
The patient's already had a conversation with their primary optometrist, because in general, the primary optometrist knows that patient way better than we are going to know that patient when they come into our office, because they've, in most cases, have been seeing that patient for many years. So they have a good understanding of that patient's visual needs and their likely goals for after surgery. And so they're probably better equipped to have that initial conversation than we are in terms of making a recommendation based on their visual goals. And, when we start talking about these different IOLs, this is a big decision. And so if we just throw all this information at them in one single visit and expect them to make a decision in 15 minutes, it's easy for them to feel overwhelmed or have some decision paralysis. So I think if the primary OD or the primary optometrist can have this conversation and set the stage early on, I think it only helps the patient be a more informed person and make a better decision.
I'm with Tanner 100% here. Finally, on the same page.
It only took us a half hour to get a line, Barbara.
Yeah, it feels good. It feels good, folks.
Thank God we got 2.5 hours left.
Yeah. One thing that I've always said, it kind of guides me in how I try to practice, is an educated patient is a happy patient. And to take that a step further, right? An educated patient with time to consider is a really happy patient, right? Because that allows them that process that everybody has to go through to not feel like something is an impulse, right? They go through this, okay, kind of in their mind testing out different scenarios of the what was presented to them. And the earlier they have that opportunity in the process after having found out they need cataract surgery, I believe the happier we can make that patient, regardless of which lens they end up choosing.
That's a great point. Keith, other thoughts on that?
I agree 100% with both those guys. The primary care optometrist is seeing that patient more often than we see him. They know him better than we know him. It's one of the reasons I love our See and Do program so well, is because a lot of times the optometrist will have that conversation with the patient, and they don't necessarily have to get into all the nuts and bolts of every little optics of every lens, but just give the patient somewhat of an idea about different options. And then in our See and Do program, our patients are getting called, they're getting videos, they're getting pamphlets. One of our doctors is calling them before they come in. So they're hearing about this stuff 3 and maybe 4 times before they even come in for an evaluation. And so I feel like that has just alleviated a lot of anxiety from the patient's perspective. They can involve family members in their decision-making process too. And that's just been a game changer. And again, we're blessed to be able to work with a lot of very knowledgeable optometrists that are educating on the front end of this whole process.
Yeah, that's beautiful, Keith. And I think, Brandon, the See and Do process was something that started at Vance Thompson Vision a little bit before you joined, but can you walk through that from a patient experience perspective for the patient, what that involves and why we've found that to be in our region a really nice win for a lot of our patients?
Yeah, this is a great question, and I wonder if we'll have listeners from outside of our region that might seem a little foreign to, but the Midwest is big. There are vast expanses of ranch and farmland and rolling hills, and it's beautiful. Come visit. But the reality is, a lot of our patients are coming from a long ways away, and it's a meaningful practice to try to limit how much they want to travel. And by the way, they're patients with cataracts and they need a driver, and a lot of the coordination has to take place in order for them to have surgery. And so what a See and Do is for that patient is an alert from their doctor that they're interested in this program, and our team jumps into action. And basically we've got patient advocates that specialize in connecting with these patients ahead of time, having conversations with them, sending them a folder of information, from maps on how to get to the clinic and surgery centers to their IOL options to start those conversations, which can then be continued by one of the doctors in the office, oftentimes, who may call that patient before they arrive, so that this all feels like a connected experience to that patient. And then they're anticipating with excitement instead of anxiety that day of surgery. And that day comes and they come and see us for not only their surgery, but we do the evaluation that day too, right? And we go through all of the stuff that we normally would. It's not abbreviated in any way, except in the perhaps the counseling and the decision making, because a lot of that stuff can take place ahead of time too. And so it's a beautifully efficient process to have an evaluation and surgery on their first eye that same day. And one of the things that we've tacked onto that program is what we call next day surgery, or close sequential bilateral cataract surgery. Instead of doing one eye one day and one eye the next week or 2 weeks apart, we knock them out in back-to-back days. And so from a patient experience standpoint, our folks from Western Nebraska love this, because they come stay overnight one night in one of our preferred hotels, and back the next day for surgery, and home to their local optometrist or eye care provider. And it works really, really beautifully.
Could they go watch the Huskers the day after their surgery too?
Yeah, depends on how disappointed they want to be with not their vision. I love the Huskers. Not their vision.
We're talking about volleyball.
Yeah,
yeah. We're winning a national championship next year.
That's right. Next year.